Okay. So this is the American Society of Echo position. This is a 2017 paper, but it's the most current one on um, aortic stenosis. So we're gonna go through it really quickly, and you know, you essentially need to know everything in this document. Okay. Um, okay. All right. So. So in the introduction, so everything is very important in this document, so you need to follow it closely. So aortic stenosis has become the most common primary heart valve disease and an important cause of cardiovascular morbidity and mortality. It's very common. And because it's very common, you need to know how to assess aortic stenosis thoroughly. Okay? Echo Echocardiography is the key tool for the diagnosis and evaluation of aortic stenosis and is the primary non-invasive imaging method for aortic stenotic assessment. Diagnostic cardiac catheterization is no longer recommended, except in rare cases when the echo is non-diagnostic or discrepant with clinical data. 10, 20 years ago, when someone presents with aortic stenosis, before we take them to surgery and fix the valve, they would have to go through the cath lab where you do a catheterization to confirm if the severity of the aortic stenosis. Today, someone with aortic stenosis, they can be completely evaluated using echo, and then from the echo lab, they can go to surgery to have the valve replaced. The only reason for them to go to the cath lab if you suspect coronary artery disease. Okay? So that is one of the reasons why the echo has to be done properly because you cannot give faulty results and expect for that patient to go straight to the operating theater. Okay? So, all right. So because the clinical decision making is based on the echocardiographic assessment of the severity of the aortic stenosis, it is essential that standards be adopted to maintain accuracy and consistency across the echocardiographic lab when assessing and reporting AS. Basically, what they're saying, you need to know what a proper and a good echo in assessing an aortic stenosis, and you need to do that because the severity is going to depend on the echo findings. So you have to know how to do a proper study. Recommendations for the echocardiographic assessment of valve stenosis in clinical practice were published in the European Association of Echo and the American Society of Echo in '09. So the basic stuff is in the '09 paper. The aim of the '09 paper was to detail the recommended approach to the echo to the echocardiographic evaluation of valve stenosis, including recommendations for specific measures of stenosis severity, detail of data acquisition, measurement, and grading of severity. So the '09 paper deal with the basic, you know, assessment and the grading of the severity. These '09 recommendations were based on the scientific literature and on the consensus of a panel of experts. Since publications of the '09 document, numerous new studies on aortic stenosis have been published, in particular with new insights into the difficult subgroup of low gradient AS. So we have a group of patients who have low flow. And as when we did hemodynamics, you know that the gradient is dependent on the flow. The greater the flow, the greater the gradient. The lower the flow, the lower the gradient. So we have a group of patients who, because they have low flow, the gradient across the valve is low. And some of these patients really do have severe aortic stenosis. If you remember, we use gradient to assess the severity of the aortic stenosis. Okay? So the greater the gradient, the greater the aortic stenosis. In particular, we said that if the mean gradient is greater than 40, then the patient has severe aortic stenosis. But you do have some patients who have a low flow and the gradient, the mean gradient is less than 40 and they still have severe aortic stenosis. So you need to know how to tease out those patients. Okay? So accordingly, a focus update on the echocardiographic assessment of aortic stenosis appeared to be a needed document and is now provided with this document. So in this is the 2017 paper. In this paper, there are certain things that were emphasized. Again, the low flow, low gradient aortic stenotic patient, and then how to assess these patients. So it's crucial. So if someone comes to the echo lab and you do your continuity equation and you get a valve area of say 0.9 centimeters squared, just looking at the valve area itself, that would qualify as severe aortic stenosis. And we like to have everything matching up. So the mean gradient should be greater than 40 millimeters mercury. But if you're getting a mean gradient of say 25, 30 millimeters mercury, you need to figure out what's going on here. Is this a low flow situation, a low gradient? Because if you have low flow for whatever reason, the gradient can be low. And you need to know how to tease out those patients and those patients who have real severe aortic stenosis. You need to send them for surgery. All right. So that is one of the things that this paper uh, delve into big time. All right. So it is essential in clinical practice to use an integrative approach when grading the severity of AS, combining your Doppler and your 2D data as well as the clinical presentation and not relying on one specific measurement. So in echo, we're going to use the Doppler and the 2D data. But remember, clinical presentation is very important. So there are certain things that if someone really have severe aortic stenosis, there are certain things that they should have clinically. And if you, in your clinical assessment, if you don't get those things, then you need to, because you remember you can make mistakes in your echo, and people do make mistakes in doing the echoes. So if you have an astute clinician and if they get certain features which is not in keeping with severe aortic stenosis, regardless what the echo finding shows, you know, it might not be severe aortic stenosis. And some of those patients you have to take to the cath lab to confirm, or you need to repeat the echo and make sure that the echo is done properly. So loading conditions influence velocity and pressure gradient. Again, if you have a low flow situation, if the flow is low, the velocity and hence the pressure gradient is going to be low. Remember your modified Bernoulli equation gradient is equal to 4v squared. So if you have a situation where the velocity is low for whatever reason, then the gradient is going to be reduced. Therefore, these parameters are very dependent on intercurrent illness of the patients with low versus high cardiac output. So what we're saying is, if the patient is having a high cardiac output, so the patient is have a fever, is febrile, patient is having some fistula or whatever, which increase cardiac output, that in itself can give you a high gradient because you have increased flow. And again, if you have a situation with low flow, for example, the patient may have an ejection fraction of 10%, not enough flow across the valve to generate a significant gradient. So those are some of the things that can affect gradient and the echo assessment of aortic stenosis. In addition, irregular rhythms or tachycardia can make assessment of aortic severity challenging. So again, you need to have a protocol. You need to do very good assessment echo wise. Ideally, when someone comes to the echo lab, you need to have a heart rate. You need to know what rhythm the patient is in. You need to know the blood pressure. Okay. So these are things that you need to record or document when the patient comes to the echo lab, because it's important to use this information when you're grading stenosis. So these guidelines provide recommendations for recording and measuring aortic stenotic severity using echo. However, although accurate quantification of disease severity is an essential step in patient management, clinical decision making depends on several other factors. Most importantly, whether or not symptoms are present. So, not because you get something that's severe, you're going to rush the patient uh, to surgery. Um, we like to see the patient having some type of symptoms to go along with that. Okay, so you need to combine the clinical information along with the echo information. So this document is meant to provide echocardiographic standards and does not make recommendation for clinical management. So this is just the echo findings, and we divide it into mild, moderate, and severe. Um, then the clinician, the cardiologist have to sort of marry the echo and the clinical presentation and determine if this patient should go on to surgery. So if you've been keeping with current guidelines, you see when the current approach to valvular assessment, any valvular assessment, is not only the severity that you'll get on echo, but the clinical presentation. So you will have severe, say, let's talk about aortic stenosis. So you will have someone with severe aortic stenosis, asymptomatic, severe aortic stenosis, symptomatic. So when we look at valves today and we classify in severity, that is how we're doing it. Severe stenosis without symptoms or asymptomatic, severe stenosis, symptomatic. You know that once you have any severe valvular lesion and you're symptomatic, you need to go on to surgery. All right. When we're assessing aortic stenosis, we need to there are a number of things that we need to do. We need to optimize the LVOT assessment. You know that in the parasternal long axis view, we measure the LVOT diameter. So you need to know how to optimize that. In the four chamber view or five chamber view or apical three chamber view, We look at the LVOT velocity or the VTI. Okay, you need to know how to optimize that. And then when we talk about low flow, low gradient aortic stenosis, reduced ejection fraction, that is the patient with an ejection fraction, say 10 to 20%. And because the heart muscle is weak, they cannot generate a sufficient flow then across the valve to generate that gradient. So you get a low velocity, and when you square the velocity and multiply it by 4, the gradient is low because of the weak heart muscle reduced ejection fraction. You also have another group of patients who have low flow, but their ejection fraction is normal. They have low flow, low gradient, and these are uh, those patients who have a small LV cavity. If you look, the heart the cavity is small. So because the cavity is small, they cannot have that increased flow across the valve to generate a sufficient velocity. So when you square that velocity, multiply it by 4, you for you to get a decent gradient. So these two scenarios very important to assess these patients properly. So the low flow, low gradient because of a reduced ejection fraction, and the low flow, low gradient patients who have just a small LV cavity and they cannot generate sufficient flow across the valve to get a decent gradient. Uh, and then the new classification of aortic stenosis by gradient, flow, ejection, and ejection fraction. Um, and okay, so let's move on. We're going to look at the etiology and the morphology, a morphologic assessment of aortic stenosis. So the most common cause of valvular aortic stenosis are calcific aortic stenosis of the tricuspid valve. So what we're saying is that, and these patients are usually the older patients, right? So they do have tricuspid aortic valve, but it is calcified and stenotic. It's aortic stenosis of the aging population. Okay. Also, very common is your bicuspid aortic valve with superimposed calcific changes. These are usually younger patients. Okay. They have bicuspid aortic valve, and because of the abnormal flow dynamics, they tend to get calcification. The valve becomes stenotic. And rheumatic valve disease can also cause aortic stenosis. Not very common in the United States and in Europe, but in the tropical countries, it's more common. So these are the more common cause. Okay, your calcific uh, stenotic tricuspid aortic valve, bicuspid aortic valve with superimposed calcific changes, and rheumatic valve disease. Congenital aortic stenosis, owing to a unicuspid, is very rare, does occur. So you'll find that in young, very young patients. You tend to get more dysmorphic features, including severe thickening and calcification, and associated significant concomitant aortic regurgitation. So these patients tend to have aortic regurgitation as well. Okay. In Europe and North America, calcific aortic stenosis represents by far the most frequent etiology, uh, with the prevalence of a bicuspid versus tricuspid valve in the underlying anatomy being. So basically, what we're saying is, in the older patients, say older than 75, that they're going to have a tricuspid valve which is calcified. Okay, so you have to know the difference. So when a patient comes to you, you should be able to quickly figure out what's going on. So if someone 85 comes to you and they have aortic stenosis, you should automatically think uh, it's a calcified tricuspid aortic valve. This up here, it tends to give you an idea of just a normal aortic valve with three cusps. Okay, rheumatic aortic valve tend to have calcification at the leaflet tips, at the tip of the leaflets, so you get these calcification. Okay, and then for older individual with a tricuspid valve, they tend to have calcification in the cusp. Okay, these patients, all these patients have three cusp. Okay, as opposed to your bicuspid aortic valve, where you have fusion of the right and left cusp. You have fusion of the right and left cusp. When the valve closes in systole, you get a raphe. So you cannot make your assessment of a bicuspid aortic valve when the valve closes in diastole. Okay? When the valve is closed in diastole, you can't make an assessment. The valve has to be open in systole. Okay? So when your normal tricuspid valve opens in systole, it has this sort of triangular configuration. Even the rheumatic when will still have a triangular, and your calcific still look like that. Your bicuspid aortic valve, however, when it opens, it has this ovoid configuration, and you can see that there is fusion of these two cusps. And so the most common etiology is fusion of your right and left cusp. Um, so again, bicuspid aortic valve causes stenosis more common in younger patients, less than 65, while rheumatic aortic stenosis is rare in Europe and North America, still prevalent in tropical countries, however. Anatomic evaluation of aortic valve is based on a combination of short and long axis images. So again, you have to do your short axis at the level of the aorta, and you want to see the aortic valve opens. Okay, don't look at the valve when it closes and you say, yeah, uh, there are three leaflets, because you see something looking like this. Okay, you cannot make the assessment when the valve is closed. So you have to look at the valve in systole when the valve is open. Okay. Um, so a bicuspid valve most often results from fusion of the right and left coronary cusp. So the right and coronary cusp is the most common fusion you'll get in a bicuspid aortic valve, resulting in a larger anterior and a smaller posterior cusp. And that occurs in about 80% of the cases. Okay, so we're not going to belabel that, but you know, in younger individual, if you see aortic stenosis, it's probably most likely a bicuspid. Older individual, calcification. So calcification of a tricuspid valve is most prominent in the central and basal portion of each cusp. Okay, so while commissural fusion is absent, so essentially you're gonna have prominent calcification in the central and basal portion. So calcification of a bicuspid valve is more often asymmetric, so it's not symmetric, asymmetric. The severity of valve calcification can be graded, you know, but you need to say, well, mild, moderate, or severe. However, you have to be careful in very young individual if they have bicuspid aortic valve and it's stenotic. Sometimes they don't have any calcification. Okay, so you have to be common. Also, very important, radiation-induced aortic stenosis represents a special challenge in the aortic, as the aortic valve is often heavily calcified in a younger population, making the assessment of aortic valve morphology, and if they're difficult. So you can get radiation-induced aortic stenosis. Another important point, even though we're talking about valvular aortic stenosis, be careful because you can get subvalvular or supravalvular stenosis. And sometimes it's very difficult to distinguish, what you're dealing with. However, you need to look at the valve. If you look at the valve and the valve looks like it's opening and closing very well, then you have to look for one of these things, the subvalvular or supravalvular stenosis. Okay? So if you just look at Doppler and you're not looking at, because some people just do measurements and stuff. They don't business what they're seeing. Look at the valve. If the valve is opening and closing well, then you might be dealing with either subvalvular, so sometimes you get a membrane below the valve, or supravalvular stenosis, where they just above the valve, the aorta narrows quite a bit. Okay, so you have to be aware of those conditions. Um, Supravalvular stenosis is uncommon and typically results from a congenital condition, such as the Williams syndrome. So once you see these patients, they look classic. Okay, Williams syndrome patients look classic, and when you look at the ascending aorta, uh, we're probably right at the sinotubular junction or above the sinotubular junction, you get this severe narrowing. It looks like a hourglass. So you need to look at what you're dealing with. Don't just write down numbers and stuff like that. So in supravalvular stenosis, uh, flow acceleration is noted above the valve, which confirms the morphologic suspicion of a narrowing, typically at the sinotubular junction with or without extension into the ascending aorta. So in addition to doing measurements, look, okay? Um, all right, so a couple of things when you're doing your measurements, because you want to minimize error. So your LVOT diameter, it's crucial that you do your measurements in the LVOT accurately, because remember, you're going to square the diameter. When you're using the continuity equation, the aortic valve area is equal to 0.785 times d squared times the LVOT TVI divided by the aortic valve TVI. So you're squaring the velocity. So you're going to do your 2D parasternal long axis view. You're going to zoom it. You're going to zoom it because the larger it is, you're going to reduce the error. Okay, you're going to adjust the gain to optimize the blood tissue interface. And your measurement should be from inner edge to inner edge inside the tube. That's where you're going to measure. You're going to measure in mid-systole, okay? And your measurement should be parallel and adjacent to the aortic valve or at the site of the velocity measurement, okay? Because you're going to use your diameter in the equation. When you're doing your LVOT velocity now, so it's either in the 5-chamber or the apical 3-chamber view, you're using your pulse wave Doppler, apical long axis or 5-chamber view. The sample volume is positioned just on the LV side of the valve, and you're going to move carefully into the LVOT if required to obtain laminar flow. You want to move outside of the flow convergence area because you'll get turbulence. You want to move outside of that a little bit, and that's where you're going to do your LVOT measurements. Velocity baseline and scale adjustment to maximize size of the velocity curve. Okay. The time you're going to adjust your sweep speed to about 50 to 100 millimeters per second. And so that those are the most important thing. And remember, the maximum velocity from peak of dense velocity curve, or when you're tracing your VTI, use a modal velocity. So you don't trace the outer edge of the envelope. You're going to do a modal velocity trace. Okay, and then when you're doing your aortic valve measurement, so for the aortic stenotic jet, you use continuous wave Doppler. Um, you need to learn how to use the imageless probe, the PDOF, because a lot of time you get maximum velocity using that. You want to use multiple acoustic window. You have the apical, suprasternal, right parasternal, suprasternal knot. Use multiple acoustic window because remember when we look at Doppler is angle dependent, and unless you can get the ultrasound beam parallel to the flow, you're not going to get maximum velocity. And in order to get maximum velocity, you have to use multiple acoustic window. You're going to decrease again, increase wall filter, adjust baseline, curve and scale to optimize signal, grayscale spectral display, the velocity range and baseline, adjust the velocity signal. Again, maximum velocity at peak of dense velocity curve. Okay, you don't want to go outside of that where you have those little uh, little echoes. You want a maximum velocity at the peak of the dense velocity curve. Avoid noise and find linear signals. The VTI trace, again, is going to be at the outer edge of the dense signal, so you're going to do modal trace, okay? Mean gradient calculated from the modal trace. So all of these things, you should practice and you should do, because if you're going to give accurate assessment, then you have to do those things. All right. So recommendation for standard clinical practice. Okay. We just went over that. So the peak jet velocity, all right, that's the antegrade systolic velocity across the narrowed aortic valve, or aortic jet velocity. It is measured using continuous wave Doppler. Accurate data recording mandates the use of multiple acoustic windows in order to determine the eye's velocity, because this is a Doppler technique. So you need, in order to get the eye's velocity, the ultrasound beam has to be parallel to the flow. So you can apical and right parasternal or suprasternal knot will frequently yield the highest velocity, but you don't know which one is going to give you the highest velocity. So that is why you have to use multiple acoustic window. Rarely subcostal or supraclavicular windows yield the highest velocity. Careful patient positioning and adjustment of transducer positioning angle are crucial, as velocity measurement assumes a parallel intercept angle between the ultrasound beam and direction of blood flow, whereas the direction of the aortic jet in 3 dimensions is unpredictable and usually cannot be visualized. Aortic stenotic jet velocity is defined as the highest velocity signal obtained from any window after careful examination. Lower values from other views are not reported. Okay, if you want the highest velocity. Acoustic window that provide the highest aortic jet velocity is noted in the report and usually remains constant and sequential studies. So if you get your highest velocity in the right parasternal, you need to make a record of that so that when that patient comes, that is where you're going to get your velocity assessment. Occasionally, color Doppler is helpful to avoid recording uh, the CWD signal of an eccentric mitral regurgitant jet. So be careful. It can be contaminated with MR, and you need to know how to manipulate the patient. But it's usually not helpful for S-directed jet. Angle correction should not be used because it's likely to introduce more error and given the unpredictable jet direction. So don't use any angle correction. A dedicated small dual crystal CWD transmitter is a PDOF probe. So the imageless probe is strongly recommended both because of its higher signal to noise ratio and because it allows optimal transducer positioning and angulation. So you can manipulate this transducer to get maximum velocity, particularly when suprasternal and right parasternal windows are used. However, when flow velocity is low, less than 3 meters per second, and cusp opening is well seen, a combining image Doppler may be adequate. All right, so simple things, you know, I mean, by doing relatively simple stuff, you can get a very good assessment. Okay, so again, remember when we talk about severe aortic stenosis, when you look at your jet, your aortic stenotic jet, a velocity greater than 4 meters per second is usually suggests severe aortic stenosis. Okay, so your peak velocity greater than 4 meters per second suggests severity. Mean gradient, and those of you interested in the formula for mean gradient, this is the formula. Okay, but the mean gradient greater than 40 millimeters mercury, okay, um, suggests severe aortic stenosis. And again, you have to use the continuity equation to calculate the valve area. And the continuity equation, aortic valve area is 0.785 times d squared times the LVOT VTI divided by the aortic valve VTI. And you want to see a valve area less than 1 centimeter squared. You can use velocity in your calculation, but you need to state that, and it's the LVOT velocity divided by aortic valve velocity. You know, we call this the simplified continuity equation, but the full continuity equation you use your VTI. Okay, the simplified continuity equation you can use velocity, but the valve area should be less than 1 for severity, and then you can use a velocity ratio. Okay, so basically when you're doing your velocity ratio, you use your LVOT velocity divided by your aortic valve velocity, and if that is less than 0.25, it suggests severe aortic stenosis. We also call this the dimensionless index. So because you're just using it has no dimension. You can use either velocity or VTI. If you're using the VTI, then it's the LVOT VTI divided by the aortic valve VTI. And if it's less than 0.25, it suggests severe aortic stenosis. Or you can do planimetry. In the short axis view, when the aortic valve opens, you can just do planimetry. Again, less than 1 centimeter squared suggests severity. So you need to know these numbers. Okay. All right. So these are So this is how you do a modal plane. You don't go on the outside. You want to where you have the dense echo. That is where you're gonna plane. And then for the peak, you don't go where you have these little outlying uh, echoes. You go where it's dense. Okay, that is how you measure your peak uh, velocity. Um, okay, this is just a contamination. So this patient also have outflow obstruction. You can see that there's, so in addition to the AS, you can see that there's this dagger shape which suggests uh, outflow tract obstruction. Again, when you're doing your measurements, okay, your LVOT, um, so you want to be in front of the valve, okay? So you can be, you can be 3 millimeters, you can be three to 10 millimeters in front of the valve because the LVOT is supposed to be rectangular. So, it should be the same measurements anywhere along here, okay? You wanna, so you're gonna be from inner edge to inner edge or just the inside portion, okay? This is when you're measuring the LVOT diameter. Again, you want to measure the dense portion. You don't want to come outside of that, the dense portion. The modal trace should be at the dense portion for modal trace, okay? Again, remember, accurate assessment is crucial because patients are going to leave from your echo lab to the operating theater. You don't want to be responsible for someone going to the operating theater that don't need to go to the operating theater. Okay, so all right, so this is how you do it. Again, remember your LVOT measurement should be parallel to the LVOT plane. Okay, so we don't want to see any crooked measurements. Okay, it should be parallel. Sorry, it should be perpendicular to the LVOT plane. So the LVOT plane will be the LVOT plane is going to be like this. Okay, so this should be perpendicular to it, 90 degrees. All right, so we don't want any crooked measurements because I've seen it. I've seen measurements like this, and I've seen measurements like that. So be careful. It should be perpendicular to the LVOT plane. So no fancy measurements. And everybody should know the continuity equation. You should know both the full continuity equation and the simplified continuity equation. So, and this is the grading system that we're using. Okay, so for severe aortic stenosis, we talk about a peak velocity greater than or equal to 4 meters per second, mean gradient greater than or equal to 40, valve area less than 1 centimeter squared, and this is your dimension, this is your index aortic valve. So that is if you divide it by the body surface area, should be less than 0.6 centimeter squared per meter squared, and this is your velocity ratio or your dimensionless index. Severe is less than 0.25. For mild, these are the numbers for mild. Peak gradient 2.6 to 2.9 meters per second. Mean gradient less than 20. Valve area greater than 1.5. Your index aortic valve area greater than 0.85, and your velocity ratio greater than 0.5. anything that falls between mild and severe is moderate. So for your sclerotic patient, the velocity tends to be lower. Okay. Um, and then again, if you're going to do planimetry, that is in your short axis view. You can do that with transesophageal echo or your regular 2D. All right, so we are not gonna look at the special scenarios today, but our next session we're gonna look at the low flow, low gradient scenarios. So the low flow, low gradient patient may have a reduced ejection fraction, or they may have a normal ejection fraction. So we're going to look at those special cases. So we're not going to do that tonight, but we'll reserve a separate lecture for that.